Hello everyone and welcome to Edusurg Clinics where we discuss some key topics related to common medical and surgical practice. Now whether you are in MBBS or post-graduation in medicine or surgery, this topic is very commonly asked and that is obstructive jaundice or surgical jaundice. What we are going to do is that with the upcoming next exam or the national exit test as well as the OSCE pattern that is being introduced, we are going to develop some videos on clinical topics where an approach will be shown on how to prepare these topics and what are the key points that remain the same. I have not given next exam. No one has given next. I have an MRCS where we give OSCE, but these exam patterns can be different. But the key point to understand from this video is that the topics remain the same. And if you understand the basic concepts well, whether it is the next or the OSCE exam, you are going to do well. So let us understand the basics of obstructive jaundice. So now this image may be a sign of beauty to some, but when we see this, we are definitely worried. Like this is one of the most common presenting features of obstructive jaundice. Okay, so in this talk, what we are going to do is we are going to cover the basics of bilirubin metabolism as relevant to clinical practice. We are going to see the classification, and I know it may seem very old, 1983, but this one classification has stood the test of time, very commonly asked and very practical. That is the Benjamin classification. Then we will see the approach, and this approach is the part where you will get a lot of multiple choice question for your next exam papers, and there are also a lot of key points that you have to remember when giving the practical part of the next exam or the OSCE exams. We will look at the imaging approach, USG, and the standard question of CT scan versus MRCP, as well as the invasive test, percutaneous, transhepatic cholangiography, and ERCP. So, if you know all these points and the practical applicability of all these points, then the case of obstructive jaundice as well as the multiple choice questions on obstructive jaundice become very clear. So let us see them one by one. So going into bilirubin metabolism, this single slide covers the entire metabolism. You need resources like these to revise your subjects before exams like multiple choice exams and OSCEs. So in bilirubin metabolism, when we are discussing obstructive jaundice, the part marked by red is important. That is what happens is that the bilirubin after conjugation finds it difficult in getting excreted. That is because of obstruction in the excretion pathway of bilirubin, and that is what leads to obstructive jaundice. Just in brief, extravascular or intravascular hemolysis leads to production of unconjugated bilirubin, which binds with albumin in the blood, then traverses through the hepatic sinusoids into hepatocytes. The unconjugated bilirubin then gets conjugated to glucuronic acid, so that forms the conjugated bilirubin. The conjugated bilirubin then passes through the biliary system, enters the duodenum, enters the small intestine, partly gets converted into urobilinogen through bacterial proteases, that is around 10%. The urobilinogen again enters the portal system, enters the blood, and through the kidney, urobilinogen is excreted in urine. The part which is not converted is excreted in feces, which is 90% of the bilirubin. So when the stercobilinogen is not formed, the feces are not having the standard color. That is why clay colored stools is one of the standard feature of obstructive jaundice. Now going to classification, there is a very practical way of classification which is organ wise, that is hepatic jaundice, then jaundice due to problems in gallbladder and bile duct, pancreas, and extraluminal causes like lymph nodes. Okay. Again, if we go to disease-wise classification, it can be stone disease, it can be iatrogenic, like endoscopic interventions, okay, or post-surgery interventions. There are other benign causes like cholangitis, pancreatitis, right, chronic pancreatitis, and there are malignant causes. So there is an etiology-wise classification, organ-wise and etiology-wise. If you combine these two, is what leads to the Benjamin classification, but it is very standard. Okay, it gives you a clinically relevant picture of jaundice and a hint towards the diagnosis. So let us look at the types of obstructive jaundice in Benjamin classification. Type 1 is complete obstruction, that is, so example is complete ligation of CBD or primary or secondary liver tumors which completely block the bile duct. Pancreatic tumors again which completely block the bile duct, cholangiocarcinoma, and complete stent block, right? So if your patient has undergone an ERCP or PTC and then presents with complete obstructive jaundice, you may be looking at a stent block, which is type 1 or complete obstruction related obstructive jaundice. Type 2 is intermittent obstruction, which can be due to recurrent passage of CBD stones or worm in common bile duct or periampullary neoplasms. As we know, the neoplasms slough over time, which cause relief of jaundice, and then it again starts blocking the duct, and this cycle repeats itself, which is known as waxing and waning of jaundice. We'll see this in upcoming slides. This is again an example of intermittent jaundice. Okay, duodenal diverticula occasionally hits on the ampulla, produces obstruction. Once it gets lifted, the obstruction is relieved. Similarly, choledochal cyst, bile duct papilloma is rare, and hemophilia is also extremely rare. But these are intermittent types of obstruction, which is type 2 obstructive jaundice. Coming to type 3, here you have incomplete obstruction but chronic, something like an evolving common bile duct or common hepatic duct stricture, right, which is also seen in chronic pancreatitis. The bile duct is narrowed, but it is not completely obstructed. Okay. Another example is biliary atresia and cystic fibrosis. Now, type 4 is segmental obstruction, and this is very classical of primary sclerosing cholangitis. Okay, you will see segmental obstruction in primary or secondary sclerosing cholangitis. New types of cholangiopathies that are being identified, like IgG4 related cholangiopathy or autoimmune cholangiopathy or HIV related cholangiopathy, all these usually have segmental obstruction. Trauma can be iatrogenic in multiple places, cause short segment strictures and segmental obstruction, but classically type 4 is related with sclerosing cholangitis. Other causes which are not covered in the Benjamin classification, they sometimes also label these at level 5 or type 5. And this is basically lymph nodes at the porta hepatis. These lymph nodes compress the bile duct or hepatic duct from external side and lead to jaundice. The lymph nodes can be due to tuberculosis, very common in India, lymphoma, as well as metastatic lymph nodes. So this is a very practically relevant classification. It answers some of your multiple choice questions also, and it also helps in analyzing the patient and coming to a diagnosis. So the key to your entire obstructive jaundice case is that history examination and a support of laboratory investigation can give you or at least give a strong hint toward diagnosis in 75% of cases. And this is a line from a very reputed book. So it is not personal experience. It is a very well-known fact that if you take a good history and a good examination, don't miss out on points that are mentioned in this video, and do good laboratory investigation, there is a good 75 to 80% chance that you will know or at least have an hint or a good idea towards the diagnosis of your patient. So when you are doing clinical history and examination of your patient, what are the goals? The goals are to confirm that the patient has an obstructive jaundice. So identify the symptoms and signs of obstructive jaundice. Then identify the severity of jaundice. Okay, whether the bilirubin is 10, 20, 30. Okay, then look at the level of obstruction and the type or cause of obstruction. Okay, so if you can answer these four questions in your patient, you very clearly know what is causing the obstructive jaundice in your patient, right? So now going to some of the commonly asked questions in history and examination. The most important part to remember is that whenever you are answering any question, regarding any clinical case, always start with demography, then go to symptoms, then go to signs, then go to examination. So that is how we are going to see how these points apply to obstructive jaundice or a case of jaundice, right? So when you are taking history, you don't know whether a patient has obstructive jaundice. So we will answer the 4 points that we have seen with the help of history and examination. Okay. What are the common points? The common points which are pathognomonic of obstructive jaundice are high colored urine, clay colored stools, and pruritus, right? So, if the patient has these three symptoms, you know that your case is obstructive jaundice. Always rule out the age of the patient because higher the age, more the chance of malignancy. Gender is always important because gallstones more common in females. Sclerosing cholangitis, some types are common in female, right? Some types are common in male. So you should be aware of all these points when you are taking history. History of alcohol, then you are looking at maybe hepatocellular jaundice with cholestasis, right? And also history of smoking, which are again risk factors for cancer as well. Okay. Other symptoms can be fever with chills and pain. We know the Charcot's triad, pain, fever with chills and intermittent jaundice, classical of CBD stone or worm. And if your patient also has hypotension, tachycardia, and altered sensorium, then you're looking at Reynolds pentad, right? So Charcot's triad and Reynolds pentad again commonly asked questions. Another important part in the history is past history, history of surgeries, and history of associated diseases. So these patients can have history of injection, maybe injectional drug use, multiple blood transfusions, especially in the period before 1980s, where the testing for infections was not standardized. Tattooing, a modern cause of transferring hepatitis, right? Multiple sexual partners, again, an important history. Again, all these mark towards hepatitis. Family history is important. History of biliary surgery, liver transplant, or any intervention in the biliary tree can lead to iatrogenic strictures. So this is also an important point. History of cholecystectomy is important because then the patient may be having post-cholecystectomy syndrome. If there is history of ulcerative colitis like symptoms or the patient is a known case of ulcerative colitis and now present with obstructive jaundice, a very high likelihood and something that should be ruled out is primary sclerosing cholangitis. So a lot of multiple choice questions, a lot of pointers in your history are mentioned in this single slide that can help you in narrowing down your diagnosis to a particular cause. Another point in history is the type of jaundice. Okay. Is it painless and progressive jaundice? Is it fluctuating and waxing and waning of jaundice or intermittent jaundice, right? These two are very important questions when you take any history in a patient with jaundice, okay? Progressively increasing jaundice can be painful or painless. Painless progressive jaundice has very classical diagnosis, that is CA head of pancreas is the most common, followed by periampullary carcinoma, followed by carcinoma gallbladder, followed by cholangiocarcinoma. Okay. When we talk of waxing and waning of jaundice, remember that the waxing and waning typically has been described for periampullary carcinoma. And in periampullary carcinoma, this waxing and waning occurs due to sloughing and regrowth of tumor. So this does not happen in days, it happens in weeks. Okay. So if your patient has a 3 month history, there can be a waxing and waning of jaundice. But if the patient has a 7 day history, then this point should not be mentioned because waxing and waning takes time, right? Again, loss of weight and anorexia, important points in history and suggest malignancy. Symptoms like steatorrhea, malabsorption, new onset diabetes, new onset pain and jaundice, very common in patients with chronic pancreatitis with biliary stricture. So these two slides in together give you most of the points that you need to remember, understand, have an applied knowledge of these points so that you can answer any question and treat any patient who presents with obstructive jaundice. Now coming to examination, and this slide has around 20 multiple choice questions. So Understand all these points and you can answer any question in relation to obstructive jaundice. Yellow is discoloration of sclera, mucous membrane, and skin is classic of jaundice. Scratch marks are more common on extremities. The patient can have bradycardia, which is due to deposition of bilirubin on the SA node, right? Palpable gallbladder in presence of painless jaundice, Courvoisier's law, which is a marker of malignancy. It has an exception which you should remember. I'm not going into details of Courvoisier's law, but remember the exceptions of Courvoisier's law as well, right? When the gallbladder is not palpable and the patient has painless jaundice, you are looking at hilar cholangiocarcinoma because the block is above the junction of the cystic duct to the common hepatic duct, and that is why the gallbladder is not distended and therefore not palpable, right? Not palpable gallbladder with painful intermittent jaundice. So we are talking of type 2 Benjamin classification. And if you recollect, commonest type 2 Benjamin is CBD stone. So not palpable gallbladder, intermittent painful jaundice seen in patients with CBD stone. Never forget to examine the supraclavicular node in cases of obstructive jaundice, as it's a marker of advanced malignancy. If there is presence of splenomegaly or ascites or both, you may be having a case of chronic liver disease with portal hypertension with jaundice, or a case of portal cavernoma cholangiopathy or portal biliopathy, or it may be secondary biliary cirrhosis. These are complicated cases, but these are asked in exam. Signs of liver cell failure are many. We can dedicate a separate video to it, but it is a marker of decompensated liver disease, right? So these are all the signs that you need to remember, interpret, evaluate, and rule out in your patient. Now coming to investigations part, I am sure most of you know alkaline phosphatase, gamma glutamyl transferase, and 5-nucleotidase are the three liver enzymes or biliary enzymes which are elevated in cases with obstructive jaundice. You also need to do a complete liver profile, coagulation profile, and renal profile. Look at the platelet function as the very classical marker of chronic liver disease. A simple platelet function and coagulation profile can give you a lot of answers regarding the liver function. Tumor markers, we always do CEA, CA 19.9 and chromogranin A, where there is a suspicion of neuroendocrine neoplasm. Alpha fetoprotein to be done only if you are suspecting hepatic lesion, like HCC. Urine tested for bile salts, pigments, and urobilinogen. Stool test for occult blood. Melena can be present in periampullary carcinoma cases. Fecal fat estimation and fecal elastase levels done in cases of chronic pancreatitis. After that, we come to imaging, right, which is the next part. And ultrasound classically shows this type of picture, which is dilated intrahepatic biliary radicals. And this is a classical picture that is seen in obstructive jaundice. Okay. So the usual first imaging investigation in a case of obstructive jaundice after the blood test is an ultrasound. As I've already mentioned, the key sign is IHBR dilatation, and it can give you the level of biliary obstruction in 90% of the cases and the cause of obstruction in 70% of the cases. However, this is difficult in obese patients or patients with cirrhosis where IHBR is late to get dilated, or there may already be atrophy hypertrophy complex and it would be difficult to interpret, right? Other important points that you can see in ultrasound is free fluid, portal hypertension, nodes, status of liver. And if you are dealing with a chronic liver disease patient, then you also can add Doppler and look at portal vein to rule out portal hypertension, collateral, size of spleen, lesions in the liver, right? So all these points can be covered in a simple ultrasound. Believe me, ultrasound can give you a lot of information in cases with obstructive jaundice. Coming to CT versus MRCP, to cut the long story short, if there is a suspected biliary pathology, now we routinely do only MRCP. Remember that MRCP by itself does not have a contrast. Bile acts as the contrast. It is a T2 or heavily T2 weighted image. If you are suspecting malignancy and you want a complete resectability workup, you can see our hilar cholangiocarcinoma videos on the channel. But then you have to advise a specific contrast enhanced liver protocol MRI with MRCP, right? MRCP by itself will not have a contrast, and this is an important point to remember. If there is a suspected pancreatic pathology and the suspicion is based on history, examination, investigations, and ultrasound, right? Then what we do for pancreas is we do a triphasic CT, okay, and we do an MRCP if we need more biliary information, okay. Otherwise, a triphasic contrast enhanced pancreas protocol CT. We have videos on triphasic liver protocol and triphasic pancreas protocol in this channel. You can have a look in the radiology playlist. But a CT is as good as MRI when it comes to pancreatic pathology. Gallbladder or hepatic mass. Now, usually these cases need both CT and MRI, but if you or your center has good facilities of MRI, then a triphasic liver protocol with liver specific contrast works wonders in an MRI when you want to rule out the differential diagnosis in hepatic mass, right? So for biliary pathology, a plain MRCP, if you are suspecting malignancy or want to plan surgery, then contrast MR with MRCP. For liver lesions, MRI now, of course, is becoming the gold standard with liver specific contrast agents. Pancreatic pathology, we still rely more on CT with help of MRCP in specific cases. Like I already said, hepatobiliary contrast of MRI is less nephrotoxic and gives excellent details. And that is why MRCP is the best non-invasive method and has replaced PTC and ERCP for diagnosis purpose. Again, very commonly asked question that now if you only want a diagnosis, then MRCP scores over PTC or ERCP. The next step after MRCP is endoscopic ultrasound. When you go into therapies, that is where PTC and ERCP comes into picture. Just a brief on PTC and ERCP. We'll not go into details as this video is predominantly aimed as the approach to obstructive jaundice. The PTC is percutaneous transhepatic cholangiography, right? You can see the PT catheter and the catheter then injects contrast. You can see a block in this scan. Excellent anatomical details can be seen. So PTC is on your right side, on your left on the screen is ERCP. This is the endoscope and the ERC wire. Then you put in the contrast, and this is how the biliary tree lights up. You can see variations in the biliary anatomy and you can plan your surgeries. Usually now these images are acquired through MRCP, and ERC and PTC are predominantly becoming therapeutic interventions. So ERCP, the benefit over MRCP, like I said, it is more therapeutic. You can do a biopsy, you can do stricture dilatation, sphincterotomy, and stent placement. However, the problems are complications. ERCP can lead to pancreatitis, can have bleeding, stents can have problems, stents can get blocked. So these are some of the problems of ERCP. And that is why MRCP has replaced ERCP for diagnostic purpose, and EUS is replacing upfront ERCP. Or you don't cannulate the bile duct in EUS, you just have a look with an endoscopic ultrasound. Percutaneous transhepatic cholangiography, a very clear-cut division is the hilum, right? For anything that is proximal to the common hepatic duct bifurcation, PTC is better therapeutically than ERCP. Same therapeutic implications like ERCP, but it can also be used when ER cannot be performed, like the patient having Roux-en-Y anastomosis, or if the patient has secondary bile duct lesions, like I said, lesions that are above the common hepatic duct bifurcation, PTC does better. So a very simple overview. We have seen the bilirubin metabolism, how it leads to various symptoms and signs. We have seen the history, we have seen the examination, and we have seen the investigation in a structured manner, the ultrasound first, followed by a decision between CT and MRI, and then a decision between endoscopic ultrasound, ERCP, and PTC. If you understand this video, maybe have a look at it 2, 3 times and grasp all the terms that I have been using in this video. I am sure that most of your questions on a case on obstructive jaundice will be covered by this video. This flowchart just gives you an overview of what I have discussed. If your laboratory studies are normal, you are looking at the other causes of skin coloration, very rarely seen in clinical practice. Important is the unconjugated and conjugated hyperbilirubinemia. Remember, in all cases of obstructive jaundice, the 4 questions that your first goal is to confirm that your patient has obstructive jaundice or conjugated hyperbilirubinemia, not unconjugated hyperbilirubinemia. Then look at the cause of obstruction, the level of obstruction, right? That is how you have to proceed in a case on obstructive jaundice. Thank you.